Okay, so I'm going to present the use of topical insulin in the treatment of persistent epithelial defects. Okay, so first, understanding the persistent epithelial defects. Overview, the persistent epithelial defects are defined as areas of corneal desepithelialization exceeding 2 millimeters that do not improve within 2 weeks despite proper treatment. These defects are often caused by factors such as neurotrophic ulcers, chronic corneal surface pathologies, or underlying diabetic conditions. So the topical insulin has emerged as a promising therapy for managing persistent epithelial defects, particularly in refractory cases. This method allows target treatments of corneal ulcers, enhancing the healing of the conventional therapies. So the mechanism of action is that insulin have the action in the keratocytes and epithelial cells that pose specific receptors for the insulin. So this enhances the repitalization. Okay, so I had a patient that I tried to she has a persistent epithelial defect and she was trying a lot with another antibiotics. So I decided to start with the topical insulin. So the patient background is a patient of 69 years old, female with no comorbidities. She presented with a vision of 2100 in the affected eye, that it was the left eye, and had been experiencing discomfort due to a persistent epithelial defect. So this was the initial examination. The corneal epithelial defect was 4.8 with 2.5 with stromal infiltration. We can see here that the epithelial defect was really big. And after she came with me, she came to the hospital. She was already like with a lot of antibiotics and lubricants like for 2 months. So prior to administration of topical, the patient had been treated with topical antibiotics and lubricants, and it wasn't improving. These conventional treatments failed to heal the persistent epithelial defect, prompting further intervention. So the methodology that I used was topical insulin, was prepared using rapid acting insulin at a concentration of 1 unit per millimeter. And this formulation leveraged insulin's cellular effects to stimulate corneal healing effectively. The frequency of the application was applied every 6 hours to maximize its therapeutic effect. This consistent application schedule ensures sustained exposure for enhanced epithelial cell migration and proliferation. I decided to keep the lubricant, so she was like it was the corneal surface hydration was supporting the healing process. And the treatment results, the treatment with topical insulin every 6 hours and maintaining lubricants, significant improve was recorded at 4 days, with progression observed at 10, 18, 25 days, and final closure by 1 month, 40 days. So this is like the progression that she had. We can see in the first picture that it was really big, and then it was like being smaller, and then the last day, that it was the 40 days, the epithelial defect was already closed. So we can see here the evolution. By 40 days, the defect had closed with minimal scarring, and the patient report improvement in vision to 200. The treatment demonstrate efficacy in managing persistent epithelial defects that we can see here the evolution. So, discussion and conclusion. Okay, so in summary, we can see that this case demonstrates that topical insulin considerably improved corneal healing in this 69-year-old patient with a persistent epithelial defect. After initiating the therapy, significant advancements were noted by 4 days, with full closure achieved within 1 month, showcasing insulin roles in accelerating epithelial repair. Historical context, this topical insulin application was in medicine dates back to the 1960s and 1970s, focusing on its potential in wound healing. So it also is reinforcing the relevance of insulin as a therapeutic agent in ophthalmology. So the conclusion of this case is that further studies are essential to evaluate varying dosage of topical insulin and their potential side effects, understanding different concentrations that could optimize treatment for persistent epithelial defects and establish a comprehensive safety profile. Also, this insulin is very accessible and easy to prepare, and it has the complication of having to be kept refrigerated so as not to lose its character. This is all the case that I have, and I wanted to present it because sometimes when we have something that doesn't feel for me was that I had this patient that she said to me, I really don't want more antibiotics. I don't want anything more because I'm really tired. I have been struggling with this 2 months. So I decided to try the insulin and it worked. So I wanted to present this case, and that's all.
Carolina, what's the cost of insulin? How expensive is it to get the treatment that's needed for the course that's needed?
Here?
Yes, for you. Yep.
I bought a bottle that was of 100 millimeters, and it was $30. But with this, I can make a full of doses because I only put 1 unit for ml, in a milliliter. So it is really, really, really cheap.
And then would the patient take that home and dose at home 4 times a day? Was that the way that that the treatment occurred?
No, I prepare, I have the insulin, I prepare in the clinic, and then I gave it to her, only the bottle, and yes, and she used it in her house.
Okay, so she has to keep it refrigerated in her home as well,
and
then dose.
Because every time that she came to the clinic, she brought it the bottle with a little refrigerated thing,
okay, yeah.
happy days.
Okay. I've never seen this done. We've never done this in our clinic in Colorado. So I understand why it's done. I understand the mechanism of action. Insulin is at the end of the day, can act like a growth factor, and it helps with other growth factors. So I understand, but I'm curious if anybody else has done it, especially the US doctors, if this is something that others have attempted.
Yeah, I'd love to hear also, because I'm thinking, what do we do now? I mean, this is the type of patient, maybe you end up with oxervate, maybe you end up with a Procara. I mean, 2 extremely expensive options. And so I'm quite intrigued. I'd love to hear from some of the cornea specialists in particular about this.
So I'm going to chime in and say, and ask Carolina,
Yes.
if you considered a tarsorrhaphy on this patient at all before progressing to using the insulin eye drops, or whether that was tried before the insulin eye drops.
I
Just
think
talking about how we would manage it here.
uh-huh. Like what was she using after?
No, you mentioned that she had antibiotic drops and lubricants.
Uh-huh.
Did anyone sew her eyelids together like a tarsorrhaphy?
No.
Okay,
Never.
okay. So to your question, Eric and Dr. Cahook, the usual escalation of treatment here for a persistent epithelial defect, at least with me, would be trying the lubricants. If that doesn't work, we would attempt a tarsorrhaphy. And if that didn't work, then we would consider, as you said, Dr. Polson, the amniotic membrane with the Procara, which is expensive. The insulin drops tend to be harder to get, and the oxyrvate is very expensive. So usually we would try and heal this more conservatively before trying the insulin drops.
So Carolina, what would you have tried if it didn't work, to Seema's point? So if the insulin didn't work, what would have been your next step?
I don't know, because it was like maybe yes, a surgery or a surgery that Dr. Capu is saying. Maybe I will consider a surgery, but I really don't know. I was only with all my faith to see it works.
Faith is a good thing. It does work, so that's good.
Sometimes.
So we have considered the insulin drops. They've just been hard for us to procure where I am. So I really haven't tried those.
Yeah.
I mean, insulin is everywhere. But yet I think to myself, if I wanted to try this tomorrow, where would I get it? How does one go about getting a bottle of insulin here in the States?
Well, for a while, it was really hard to get because there was a nationwide shortage of insulin for diabetics. And so, at least at our university, trying to get just insulin from the pharmacy wasn't a great option. I haven't tried more recently just because we tend to heal these more quickly with tarsorrhaphies or a Procara.
I'm fascinated by it, and especially since Carolina, you said you saw a noticeable difference in just 4 days. I don't see why we wouldn't at least, give it a try for a week and see if we saw any improvement and continue with it. It certainly seems like a very available and affordable and a really nice option to some of our, like Eric said, more expensive options. I'm intrigued by this very much.
And for example, I decided to try the insulin because here, if you go to the pharmacy, any pharmacy, you can buy it. And it was like a bottle, and then I decided to make the insulin. So I read it, and the doses was 1 unit per milliliter. So I have to like make maths to calculate how I make the unit in the millimeters in a bottle of 10 millimeters. So then I achieve like these doses, and I try it, and it work in this way.
Maybe if you used 2 units, she would have been good in like a week.
Maybe.
If some's good, more's better. That's always the way medicine works, right? Just increase the dose. Of course, why not?
gentamicin in the ER. BID is not working. Go to like 5 times a day. That's gonna help you.
Maybe.
Yeah, it's fascinating.
Carolina, do you have access to bandaged contact lenses or Procara? Are those options, or do you not have?
No, right now I don't have it. Like, and I can like send to the hospital in like in La Familia or in like in the Guatemala City, but she was a patient that she was really tired of being with drops.
Mhm.
So she really told to me like, I don't want anything more. Like, I really don't want to try anything more.
Yeah, it's good that this worked in that case. Yeah.
Yes.
And Claudia, Teresa, I think we've talked before. We have done some amniotic membranes, not to Procara per se, but we have done some amniotic membranes at the hospital. Am I right?
Yes, you're right, Rupert.
Mm-hmm.
We have used the amniotic membranes for some of these cases, but we usually save the amniotic membranes for tougher cases, like maybe when we remove any mass or lesion from the conch.
Mm-hmm.
And we tried, like Carolina said, the conservative medication first. Actually, I just went to these kind of ASCRS, but from Latin America a few days ago, and they are really like in the mood of using the insulin drops for these epithelial defects. And if it doesn't work, they will do the amniotic membrane or the tarsorafins, but they are using first the insulin drops or the gel or lubricants or autologous serum before any surgical procedure. It is quite like harder to get here the amniotic membranes in this in these countries, so I feel like that's why they tend to keep those procedures at last.
How often do you see epithelial defects like this coming into the clinic? Is it a frequent event coming in? Do you see, in a given month, will you see several of these?
It depends of the patient. It's not that quite common. Usually they are neurotrophic keratitis or neurotrophic epithelial defects, or maybe from a corneal surgery, maybe from a tissue removal, and maybe the patient is diabetic and it's getting quite a time to heal that epithelial defects. Also, after some bacterial keratitis, maybe like the infectious situation is like already healed, but the epithelial defect remains quite a lot. So it's not that common, but it is common.
We've had some research projects here where we've tried different polymer coatings, and Seema and others might be familiar with some of the studies, some of the smaller companies that kind of came and went, that their treatments didn't work very well. There were polymers that we used to coat the entire cornea, reverse thermal gels, so they go on like a fluid and then they gel on the eye, and then you would patch. It was very cumbersome. It didn't work very well. So I saw a couple of comments. There was a comment from Andy, and Seema brought this up. We usually go to tarsorrhaphy here, but I'll bring this up to the cornea specialists about the insulin. And when a glaucoma person goes to the cornea team and says something about insulin, they're just going to laugh and they're going to make me leave their clinic when I say it. So I'll blame it on Seema. I'll send them to Seema and they'll believe her. But we should try that here. I think it's an interesting thing that is worth, like Rupert said, it's worth a few days and just see what happens, and then maybe go to tarsorrhaphy after that. So I learned a lot from this.
I just did a quick PubMed search, and there are actually 3 articles in PubMed about topical insulin drops. I think one is from the British Journal of Ophthalmology, and I believe the other 2 are, I'm not sure where they're from, but there are actually 3 articles on PubMed for those that want to look into this further, which I was expecting to find nothing, but that's encouraging.
You think that I invented it?
Yeah.
The Carolina technique.
Right. I like it.
Well, and as Caro said, it is really cheap for us to get the insulin here because as every pharmacy, they just need like this from a general doctor signature to give you the insulin just like that. So it isn't that hard as I feel that it is in the US.
Mhm.
So for us, it's cheaper than thinking the amniotic membrane or the tersorrhaphy.
I just put a link for one of the papers. I think Eric was asking, but this was the main paper that I found that shows kind of good. I mean, some of the patients did not do well, some of them did well. So it kind of makes you wonder what's predictive of those doing well and those who are not doing so well. But again, if it's inexpensive and you have access to it, I think it's worth a shot to try it.
The only comment that I would add to that is, again, we're putting the onus on the patient
Right.
to use the drops as recommended. And the only advantage that a tarsorrhaphy, whether it's a tape tarsorrhaphy or a suture tarsorrhaphy, is that we kind of control and,
Yeah.
the onus is less on the patient and it's not a difficult procedure. And most of the time it fixes the problem, but that's the only comment I'll make.
Yeah, 100% adherence to the tarsorrhaphy, SEMA. So that's a good thing. Yeah.
But it also begs the question, and Carolina, thank you so much for bringing this up because I think it really stimulates the process of thinking. It begs the question, what else could it be good for? And if it's good for epithelial defects, could it be good for dry eye? Could it be good for, acanthamoeba? Could it be good for, it really opens up a whole, maybe that's another talk, Carolina. What other uses would insulin drops have for us? Or do you use them for other things in Guatemala other than epithelial defects?
But something that I read about the insulin in the papers was that the best like defect, epithelial defect has to be like or neurotrophic or by the diabetics, but if it is like with yields or like bacterial, it doesn't work so well. It works better with neurotrophics.
Carolina, one comment. I know we're at the end of time. This did spark a lot of discussion compared to the last session that I attended, which was a while ago. So it's really nice to have this kind of. I learned from what you were saying. Here at the University of Colorado, we've been doing studies with breast milk for dry eye and other ocular surface diseases. I don't know if our team, Emily McCourt, one of our pediatric ophthalmologists, has been leading this effort. I'll email her and see if they've tried it for persistent epithelial defects. I'm not familiar if they have or haven't, but that is something that has worked really well for dry eye and severe dry eye in some of our patients.
Wow.
I'm just thinking about like recurrent corneal erosion or something like that. Maybe it would be useful because that's always a tough one.
Yeah.
Carolina, great case.
Great.
Thank you for the information. Really, that's really interesting. We'll see where this goes. We'll have a mix between breast milk and insulin sometime.
Now you're just getting crazy. Yeah, now it's
and you mix in some glaucoma drops and you have
there you go. Now yeah.
Dry eye treated. There you go.
Melanie just got excited with that, so that's good.
Don't we just put bromonidine on everything? I thought that was the solution to everything.
All right, guys. Thank you.
Thank you. Have a good night, everybody.
Good night.
Yeah.
Good night.